Hello and welcome to Heart Truths, redefining cardiovascular care for women across life stages. My name is Adair Anderson. I'm a product marketing educator here at Vibrant, and now I'm pleased to introduce you to Dr. Sara Saul. Dr. Saul is a board-certified physician who graduated from Harvard and MIT. She practices evidence-based, integrative, precision, and functional medicine. She is clinical assistant professor in the Department of Integrative Medicine and Nutritional Sciences at Thomas Jefferson University, and the Director of Precision Medicine and Longevity at the Market Institute of Integrative Health. Her 4 New York Times best-selling books include The Hormone Cure, The Hormone Reset Diet, and Younger. Take it away, Dr. Saul.
So, hi everyone. Super happy to be with you today. My name's Sara Zoll. We're talking about cardiovascular disease in women, how it changes over the life stages. It's such a juicy topic for me because I feel like we've made so many advancements in cardiovascular disease and cardiovascular mortality, but it's pretty much all been in men. So we got to talk about the women today and also how we could be raising our index of suspicion, looking out for atypical symptoms, which you probably know about, as well as doing more advanced testing. So we're going to be talking about the epidemiology of cardiovascular disease in women. I want to identify the highest risk groups. And this starts to veer from what you were probably taught about cardiovascular disease. We're going to talk about some of the atypical risk factors. And as you may or may not know, there's more than 400 of them, including what happens in pregnancy, as we'll talk about today. We're going to talk about atherosclerosis as a chronic inflammatory process, which has the autoimmune features where the immune system is attacking the blood vessel. So this is a particular way of thinking about atherosclerosis that I learned from my mentor, Mark Houston. I did a 2-year advanced cardiometabolic health fellowship with him. And he's someone that I still use a lot for mentoring. And he also developed many of the SNPs that are at the basis of the cardiogenomics genetics tests that we've got at Vibrant, as I'll be talking about later today. We're going to talk about women's atypical symptoms, what patterns we typically see and why. And then we'll talk about midlife women and cardiometabolic risk and personalized testing. So let's start with some of the grim statistics. 1 in 3 women in 2025 will die of myocardial infarction or stroke. 1 in 3. 1 in 3. And I feel like so many women are concerned about breast cancer and Alzheimer's disease, as they should be. But really, we've got to focus on women's cardiac health and how it starts to change earlier and earlier. And I'll show you some data to support that. So 1 woman dies every 3.5 seconds. So just multiply that by the length of our webinar today. And we're losing way too many women. And I believe that about 70% of those deaths are preventable. So the prevalence is greatest in non-Hispanic Black women. It's the women who racial weathering occurs the most. So I've got a special interest in these women in particular. So if you've got women in your practice, I want you to be thinking about this with a higher index of suspicion, especially along racial lines. So here are some of the emerging data in women. So at equal age, even age 45, which is when I start doing cardiac coronary artery calcium scoring, and also CT angiograms in people that I'm concerned about. At equal age, women have more consequences from cardiovascular risk factors compared to men. So 1 in 3 women die from cardiovascular disease or stroke. This is 7 to 10 times higher than breast cancer. And younger women are actually drifting into danger. So when we look at the prevalence, when we look at the number of women admitted to the hospital with acute cardiac syndrome, the rates are increasing. Well, first, let me say the rates are increasing in terms of prediabetes and undiagnosed diabetes. So metabolic health is becoming more of a risk for women. And then when we look at heart attacks and admission for acute coronary syndrome, it's the women who are 35 to 54 who have the greatest overall increase when we look at prevalence, hospital admissions, and age categories. So you might think you don't have to worry about your female patients until they're 55, but that's not true. This is the group that has the greatest risk. And if you just imagine for a moment, your patients with polycystic ovary syndrome, that testosterone level is a predictor of future cardiovascular risk. So we think about PCOS in terms of infertility. We need to be thinking about it in terms of cardiovascular risk too. And all the damage that's happening decades earlier. So women in their 30s and 40s and 50s. So the survival for women who've got a heart attack and present to the emergency room is 2 to 3 times higher if that woman sees a female physician in the emergency room with a heart attack. So there's sex differences that we'll talk about today. Those are biologically determined. And then there's gender differences, and those are socially constructed, such as this statistic about the gender of the ER doc that you see. Now, I know the guys that are on this call are the exception because you're here, you're learning about women, you're learning about the unique features that lead to atypical symptoms. So I know you wouldn't fit in that category. We also know that hormone therapy in women has been shown to cause no harm in women who are younger. So women under the age of 60, women who are 10 years or less in terms of menopausal age. So I really believe, and I'll show you the data to support this, that women need to be counseled. 100% of women need to be counseled about hormone therapy, and we need to start it sooner. When I think about female longevity, one of the things that is important to realize is that women live longer, on average 6 years longer than men, but they don't live better. So we've got this longer life, but there's a paradox. We spend 25% more of that extra life in poor health. So this is across 45 different developed countries. It's not just the United States. The idea is that women have a longer lifespan, but not a longer health span. There's a gap. You may have heard of the Go Red campaign. So what we know is that when we look at women's awareness when it comes to cardiovascular disease, it's actually been declining. So there were studies kind of pre and post the Go Red campaign. It was found in 2009 that about 65% of women realized that heart disease was the #1 cause of death. And that number declined in 2019 to 44%. And the steepest declines were in the women who need this message the most: younger women, Black women, Hispanic women. So the implication is that we are not messaging this problem that exists for women, our #1 killer. We're saturating the message and we're not doing it well. So we've got this opportunity to really shift the way that we talk about cardiovascular disease with every female patient that we see. When I first learned about cardiovascular disease, I feel like I was taught the plumbing model, which is you've got these pipes, your pipes at birth are really clean. Over time, depending on what you eat and genetic factors, other environmental factors, how much you exercise, how much oxidative stress you have, activation of the inflammasome, those pipes become clogged. But now we realize that there's this thing of immune cardiology, and we really need to be thinking about cardiovascular disease, atherosclerosis, as a chronic inflammatory disease. So this is where I'm invoking Dr. Mark Houston in Nashville. He's taught me a lot about how there's classical autoimmune disease, which affects 4 times as many women as men. Things like rheumatoid arthritis, type 1 diabetes, Hashimoto's thyroiditis, multiple sclerosis. So that's classic autoimmune disease. And then there's the non-classic type of autoimmune disease. I wrote about this quite a bit in my latest book, The Autoimmune Cure. So I would put atherosclerosis into this category. So it's got autoimmune-like features, adaptive and innate immunity against ApoB and LDL. There's a few trials that support this. And the idea is that there's an infinite number of insults that our blood vessels encounter. Loss of nitric oxide, untreated vasomotor symptoms in women, which damages the epithelium, activation of the inflammasome, as I mentioned. So there's an infinite number of insults that we experience, women and men. But there's just 3 finite responses: inflammation, oxidative stress, and immune dysregulation. This leads to vascular dysfunction. So this is the autoimmune non-classical pattern that I'm referring to. There's other conditions that fit into this non-classical pattern as well. Things like irritable bowel syndrome. So there's a subtype of irritable bowel syndrome that fits into this category. It even has autoantibodies. I would say endometriosis, adenomyosis fits into this category. So there's sex versus gender differences. And as I mentioned before, the sex differences are biological. So what are some of the sex differences that we see that make women have atypical symptoms? Well, first, women have smaller hearts. They have smaller coronary arteries. So when there's dysfunction at the level of the coronary vessels, it shows up differently in women compared to men. And we'll talk about some of those symptoms. Women also have higher estradiol and progesterone, lower testosterone by about 10x. And the loss of estradiol, the wild fluctuations that happen in the first half of perimenopause, and then the decline that happens in the second half of perimenopause and menopause, leads to a host of insults to blood vessels, such as loss of nitric oxide, such as the loss of mitochondrial function. There's also adverse pregnancy outcomes that we see, of course, in women compared to men. And that list is pretty long. So I think of pregnancy as a stress test, and not all of our women are passing. As a board-certified obstetrician gynecologist, I think about this a lot. So I always ask my patients, and I hope you do too, I ask about preeclampsia, gestational diabetes. And I don't just ask, did you have gestational diabetes, yes or no? I ask, what was your score? Because my 1-hour glucola test in pregnancy at 26 weeks was 134. And I'm an OBGYN. I got that 134 and I thought, barely crossed under the line. But no, I had insulin resistance that got unmasked in pregnancy. And that is a future non-typical cardiovascular risk factor. You want to ask about gestational hypertension. Some people have high blood pressure without spilling protein. Even preterm delivery can suggest that there's something different about the blood vessels in the placenta, in the uterus, low birth weight babies, intrauterine growth restriction. All of these are atypical pregnancy outcomes that can map to greater risk for women. There's also more statin side effects. So we're not talking about statins today, but I feel like many women are unnecessarily treated with statins. So we've got to get better about that. Then there's these gender differences that are socially constructed. So I mentioned the study from the emergency room in Florida showing that for women who present with an acute MI, if they see a female physician, when they present, their survival is 2-3 times higher. Whereas for men, if they see a male versus female physician, their survival was the same. So that points to the atypical symptoms that we see in women. And it also points to the index of suspicion that people have. So this old idea that you don't have to worry about cardiovascular disease in women until they're well into menopause, 55, 60, 65, it's just not true. The data shows it's just not true. So we also know that delay of treatment and the use of guideline-based therapy is delayed in women. The rates are lower than they are in men. And that's a gender difference. So there's some other sex differences that I've got listed on this slide, including the fact that the menopausal transition is this time of increased vulnerability of the endothelium. So I think that one is incredibly important because when I went through my training, and I'm going to show my age here because I'm 58. I started medical school in 1989. And if you're someone who went through training like I did as a Gen Xer, there's a good chance that you were taught that women who are in midlife, so 40 to 55, 60, when they have hot flashes and night sweats, that was considered kind of a nuisance symptom, something that you could counsel women for hormone therapy or other non-hormonal treatments as a way of addressing vasomotor symptoms, maybe to help them sleep at night or to be able to function in the boardroom. But that's not the full story. The full story is that women who have hot flashes and night sweats, that's a biomarker of unstable endothelium in their blood vessels. And if it goes untreated, it becomes a greater risk for the development of cardiovascular disease, as well as cognitive decline and osteoporosis. So ask about hot flashes and night sweats, but in the back of your mind, be thinking, oh, this is another atypical risk factor for cardiovascular disease. We also know that the absolute number of deaths from cardiovascular disease has been greater in women compared to men, and that's been consistent over the past 30 years. So the mortality rates for cardiovascular disease have declined since the 1960s, but the reduction in heart disease mortality has slowed and increased, as I mentioned, for women 35 to 54. So this is where we really have to change our thinking. Women also have a higher mortality rate from myocardial infarction compared to men. And a lot of that relates to the way that women experience symptoms of MI differently, and it can lead to delay of diagnosis and treatment. So women have these unique risk factors, and I think it's important to think about this change that occurs in sex hormone production. And when we look at women over the life cycle, they tend to have a peak estradiol level around age 35. And then they've got this really sharp decline. Of course, there's some rapid fluctuation that happens initially as the control system becomes more wonky, and also as the oocytes run out of functioning mitochondria. And that's a piece that I think we really want to pay attention to. And we want to be looking at things like oxidative stress and also metabolic flexibility in women in this age category. So you may know this already, but the kickoff for this change in estrogen is that the oocytes in women.
We have lost Dr. Saul, but she will be coming back momentarily. Welcome back.
Thank you. I'm not sure what happened. Let's see. So let me pull up my slide deck again. Yes, here. So here's some of the data on pregnancy as a stress test. And I want to highlight some of the outcomes data. So look at this for preeclampsia. Preeclampsia is the thing that concerns me the most. So it doubles the risk of stroke and diabetes. It increases about fourfold the risk of future high blood pressure. It increases almost eightfold the greater risk of stroke in chronic hypertension with superimposed preeclampsia. GDM, gestational diabetes, sevenfold future risk of type 2 diabetes, doubles the risk of stroke, quadruples the risk of future MI. So you can see why these atypical risk factors are so important to be asking your patients about. There's also adverse cardiometabolic profile that we see in patients who are not getting back to their pre-pregnancy weight. I was obsessed with getting back to my pre-pregnancy weight. Although if I could do it again, I would say I'd be obsessed about getting back to my pre-pregnancy body composition, not the weight. But even so, there's greater diastolic blood pressure problems, higher HOMA-IR, higher LDL, ApoB, adiponectin, visceral fat for the people who don't get back to their original weight. So these are also the patients in whom I'm looking at cardiac genetics, as we'll talk about. So we think of midlife in women as this hormonal change, right? Estrogen, progesterone, maybe testosterone starts to change. But the bigger picture that we need to be thinking about, especially with cardiovascular disease, is that there's other systems that are drifting, including the metabolic system and the immune system. So if you look at, for instance, glucose metabolism, I've got listed here premenopause. So let's just look at the dashed line, glucose metabolism. And it goes down as women go from their 30s to their 40s in perimenopause. And it goes down even further in postmenopause. If you look at a neat immune response, it goes through this pretty dramatic change in perimenopause to menopause. And you might have seen, for instance, more vaccine reactions in your patients in perimenopause. And then the adaptive immune response also changes. So much of this then maps to this problem of the immune dysfunction that puts women at greater risk of cardiovascular disease as they traverse this transition. So some of the details on metabolic and immune signaling are given here. And if you just look at, for instance, oxidative stress or chronic low-grade inflammation, this really changes over time and becomes worse as women get into postmenopause. You can also see the mechanisms behind the decline in glucose metabolism. So when we talk about these atypical symptoms that women experience, here are what they typically describe. They don't have the crushing substernal chest pain that men do. So that's considered sort of pathognomonic for an acute myocardial infarction. But women are more likely to have nausea, dyspnea, fatigue, unexplained weakness, feeling generally unwell, pain in the upper back or the neck, a sense of foreboding. I pay a lot of attention to that. Syncope. So a lot of women have syncope and they kind of blow it off. I have seen women have syncope as their presenting symptom of a myocardial infarction. I sent that patient to Mark Houston, of course. So the presentation and diagnosis in women is different. And let's talk about the underlying mechanisms. So this atypical picture is what you want to be thinking about with your patients. The chest pressure is a more common symptom than chest pain. And women are more likely to have this thing called ANOCA, which is ischemia with non-obstructive coronaries. They also have MINOCA, which is a myocardial infarction with non-obstructed coronaries. And so the idea here is that both of these can have negative angiograms. So here we want to be thinking about coronary microvascular dysfunction, that autoimmune-like process occurring in the female heart. We want to lean more toward functional ischemia testing and refer for invasive coronary function testing when appropriate. Women have more than 100 plus symptoms of perimenopause to menopause. They're shown by age here, not all 100 of them. But we want to be thinking about heart disease, insulin resistance. And even though these are listed 55 and older, we want to be thinking about them way over here in the women who are the 35-year-olds, the ones who are having weight gain and mood swings, and maybe they're resting, their fasting glucose is going up. Maybe they've got fibroids, irritability. We want to be thinking about these conditions, these chronic conditions, much earlier in our female patients. And this, again, is where doing genetic testing can be very helpful. So I think a lot about Menopause 3.0 and how we have to think about the latest guidelines and consensus. Most of the guidelines when it comes to menopause are focused on treating vasomotor symptoms. And I feel like we need to go much broader than that. And this opinion that I have from taking care of women for 30 years is not the popular opinion. It's not what our conventional guidelines are acknowledging. But the data has been showing for the past 25 years that we should be. So when it comes to menopause and cardiovascular risk, I feel like perimenopause, which depending on how careful you are about tracking it, starts around 35. So we want to be thinking about this cardiovascular turning point. We want to be looking for the changes that occur in our patients who decide to become pregnant. We want to look at adverse changes in lipids, ApoB, advanced lipo, protein fractionation, blood pressure. So Mark Houston does 24-hour blood pressure monitoring. Do you offer that in your patients? We want to be looking at body composition so that our patients don't become sarcopenic, because that starts at age 40. The average woman in the US gains about 5 pounds of fat and loses about 5 pounds of muscle every decade, starting at 40. We want to be looking at vascular function, and we can do that non-invasively. We want to be thinking about the timing hypothesis. We want to be thinking about things like the ELITE trial, showing that early estradiol treatment slowed carotid artery intimal medial thickness progression. A lot of that gets sidelined by the misinformation and misinterpretation of the Women's Health Initiative. it seems that there's this window of opportunity. And when we start estradiol later in menopause, it doesn't seem to have an effect in terms of the carotid arteries. So I like to go much further than North American Menopause Society. I also think that the U.S. Preventive Services Task Force ratings do not go far enough. And I also would say hormone therapy is just the tip of the iceberg. We want to be thinking much further about lifestyle medicine and other treatments that can help with women navigating their increased cardiometabolic risk, including the use of peptides. So the action point here is shared decision-making to treat symptoms, to think about vasomotor symptoms not as a nuisance, but as a biomarker of future cardiovascular disease. We want to be thinking not just about hormone therapy, yes or no, but how do we personalize the route and the dose? Now, the latest guidelines are that if a woman has an atherosclerotic cardiovascular disease risk of greater than 10% or contraindication, we want to avoid systemic menopausal hormone therapy in those patients. Those are the ones that I also refer to an integrative cardiologist so that we can co-manage that woman. So here's some of the key actions, some of the things that you can start doing today in your practice. I like to screen earlier, especially women that have got those atypical risk factors like pregnancy-associated complications, autoimmune disease, starting to show early signs of the menopausal transition. I like to message smarter, have it be culturally and racially tailored, and according to life stage. I do it all the time, not just on the go red days. I test differently. I look not just for obstructive coronary artery disease. I still do coronary artery calcium scans on all of my patients at 45. I also think it's critical to treat inflammation. I think all of you are aware of that. So I'm preaching to the choir here, but I want you to be thinking about the resolution of inflammation. I want you to be thinking about what helps women uniquely. We want to be practicing timing aware menopause care. I would say that starts as early as possible. The elite study showed us that. And I think you need to shape your care of women with genetics and looking at the gene environment interface. So we want genetics together with the biomarkers. And I believe that longevity is those two things: genetics, biomarkers, and also whole body imaging. So here are some of those modifiable risk factors, many of which you've heard about, like the hypertension, looking at 24-hour ambulatory blood pressure monitoring, dyslipidemia, hyperglycemia, insulin resistance, body composition, smoking, hyperuricemia. So the cutoff, this is not just a metabolic waste product. I check uric acid in all of my patients. I use a cutoff of 5.5 in men and 5.0 in women. I don't see much elevated serum iron or ferritin in women. Usually I see low ferritin. Of course, low dietary intake of omega-3 fatty acids. So these are some of the biomarkers and risk factors we want to be thinking about. Heavy metals, that's another thing that's really critical because they tend to hit women harder than men. And we've got some slides that support that here. So let me shift to genetic testing because I think that's such an important part of this conversation. I do genetic testing for cardiovascular disease in every single patient that I see. I think it's critical. I think if you're doing biomarker testing and you're not doing genetic testing, you're missing about half the picture. So the tradition is to do it in patients who've got a family history of heart disease, or they have an unknown family history, maybe they were adopted, or they've got symptoms that aren't managed by current treatment. They've got early onset of cardiovascular symptoms, and you don't know why. But I would say most of my patients come to me because they're interested in longevity. So that's what makes all of my patients candidates for genomic testing. So I use the cardiogenetic test that's offered by Vibrant. It looks at 100 plus genetic variants, and they're in 5 different SNP categories. Number 1, lipid metabolism transport. Number 2, clotting and thrombosis. Number 3, vascular function and blood pressure. Number 4, drug response, pharmacogenetics. And number 5, inflammation and oxidative stress. So many of these SNPs were personally picked by my mentor, Mark Houston. And they were picked because they've got applicable lifestyle modifications that show improved outcomes. So it's not just checking SNPs for a theoretical benefit. It's because these are the SNPs that seem to have the highest relevance in terms of the lifestyle medicine changes that we tend to make. So here's some of those SNPs. They're listed here, and there's a few that I want to highlight. These are some of the ones related to dyslipidemia and metabolic disease, advanced predictive markers such as 9p21, and I'll talk more about that one in particular. There's also SNPs related to detoxification and methylation, and it's not just MTHFR. There's a number of methylation pathways that we want to be thinking about, the COMT pathway. So let's talk about 9p21. This is the so-called heart attack gene, and I want to talk about some of the sex differences that we see. So out of all of the SNPs, I would say this is the one I pay the most attention to. If I've got a patient, for instance, I've got a patient right now who's got an elevated LDL. She's in her 40s. She's got an elevated ApoB, and she's homozygous for this particular SNP. She's got 2 coronary artery calcium scores that are 0, but I'm concerned about her because of this SNP. So this SNP is involved in regulation of inflammatory pathways. It's correlated with adverse events independent of other lifestyle factors. The heterozygous form is associated with an increased risk of coronary heart disease and MI. It's increased about 50%, whereas the homozygous form, such as this patient, the risk is increased 100%. So Vibrant has a comprehensive evaluation of this particular gene variant, looking at 4 different SNPs. So it's associated with a greater risk of inflammation, as you might imagine, plaque rupture, thrombosis, abdominal aortic aneurysm, atherosclerotic cardiovascular disease, coronary heart disease, MI, diabetes, insulin resistance. It's an important one. And we've got some citations to support these comments. So I really believe screening patients for 9p21 is important because patients who've got this SNP have a higher need for aggressive early detection, prevention, monitoring, risk factor control, evaluation of all sources of inflammation, including environmental exposures, stress, lack of sleep, infections. I use the Institute for Functional Medicine cardiometabolic food plan in these patients. That's the anti-inflammatory diet that I use with these folks. In some of them, I go plant-based. I've been pretty impressed. I mean, I have so many patients who push back and say, do I really have to be plant-based? Couldn't I have red meat twice a week? I'll only get the grass-fed, grass-finished type of red meat. But I have seen these patients have and LDL and ApoB. That's double when they consume red meat, even when they're following the rest of the IFM cardiometabolic food plan. So plant-based diet really can make a difference in these patients. And of course, you want to minimize visceral fat, exercise 4 times per week for more than an hour each session. What I learned from Mark Houston is that should be 2/3 weight training, 1/3 cardio. Ideally, zone 2. I like in my patients 150 to 300 minutes of zone 2 for mitochondrial support. And I also like VO2 max training. So a couple things that are specific to women when it comes to 9p21. So this particular locus increases coronary artery disease in both sexes, but the inheritance and the absolute risk differs. So men tend to inherit this risk in a recessive pattern, whereas women have dominant inheritance for 9p21. We know the effect of the genotype on the age of onset is mostly found in men carrying 2 copies of the high-risk allele, and the absolute risk over 10 years is higher in men compared to women. But again, the data tends to be a little bit less in women compared to men. So I'm going to summarize, and then we're going to take some of your questions. I hope what you've learned today, if you learned nothing else, I hope what you've learned is to have a higher index of suspicion in women at a younger age, so starting in their 30s, and to be thinking about atypical symptoms so that we don't dismiss women when they present with atypical symptoms and assume that they're having a panic attack or they just need their neck discomfort treated. In terms of messaging, we need to be talking to our patients about cardiometabolic risk. And if you look, so we talked about how it's the #1 killer of women. So 1 woman dies every 3 seconds. But when you look more globally at cardiometabolic risk, 9 out of 10 of the top killers in the United States are due to cardiometabolic disease. So we need to be messaging this every day with our patients. I think it's important to systematize your intake questions to do risk calculators. I work at Thomas Jefferson where I see executives, and so the risk calculators for the atherosclerotic cardiovascular disease 10-year risk is automated and Epic. I also automate the orders for coronary artery calcium scoring as well as CT angiogram. There's equity actions. We want to be reaching younger Black and Hispanic women. I think it's critical that you do genomic testing like the Cardiogenetics test by Vibrant and to combine that with advanced biomarker panels. And I think Vibrant has a new CardioZoomer. Maybe Adair will talk about that in a moment. And then I believe that all women deserve counseling about cardiovascular disease, especially if they had any atypical risk factors, particularly in pregnancy. And then to personalize menopausal hormone therapy as early as possible. So with that, I'm going to end, and hopefully Adair will join us again, and we'll take some questions.
Thank you so much, Dr. Saul. That was a wonderful reminder of how important it is to take care of our female patients' heart. And also, I'd love to talk a little bit about the 2 Vibrant tests. So certainly Cardiogenetics is replacing the CardioX test, and it has over 100 different SNPs, so more than triple what was there before. So definitely check that one out. And as Dr. Saul mentioned, we also now have the CardioZoomer, which is a comprehensive blood test that delivers a 360-degree science-driven view of cardiovascular risk in just one panel. It examines advanced lipids, so Lp(a), small dense LDL, inflammation markers, oxidative stress, including 8-OHDG, F2-isoprostane, melandialdehyde, along with metabolic status, endothelial balance, clotting markers, All of this to reveal both traditional as well as hidden drivers of disease that a lot of standard cholesterol tests miss. By clarifying these risks related to atherosclerosis, metabolic dysfunction, hypertension, heart attack, and contributing these factors like endothelial dysfunction, oxidative injury, the report provides personalized and also actionable insights that you can use with your patients, including recommendations along with wonderful infographics. So definitely check those out. I put a couple links in the chat if you want to check those out. And we will also be including them in the email we send to everyone after this webinar, along with the webinar recording and Dr. Saul's slides. All right. Looks like some questions are coming in, Dr. Saul, so I'm going to put those on the screen now and remove the slides. It can just be us. All right. So your message, we are moving in the right direction. As women clinicians, we need to continue to mentor and model appropriate cardiovascular workups, identifying risks beyond known calculators, microvascular dysfunction, insulin resistance inherent in all women in transition. I think that was mostly just a thank you for this.
Yeah, let me say a quick thing about that, because I think a lot of folks are noticing that their female patients over the age of 35 are developing more insulin resistance, and certainly the increased hospitalization, the highest group that is showing an increase is 35 to 54. A lot of that is related to insulin resistance. So we know as estrogen starts to decline, as mitochondria become more impaired and kicks off the perimenopausal transition, one of the indirect effects is more insulin resistance. So I think diagnosing this as early as possible, also looking at insulin resistance from the gene environment interface is critical. So just wanted to add that piece about insulin resistance.
Perfect. Definitely worth saying. Very important. All right. Next question. So this particular provider specializes in ketogenic diets and would love to know if you use this diet in managing cardiovascular disease in your female clients.
I sure do. So I wrote a book about it, Women, Food, and Hormones. And it's such a good question, because what we know with keto is that it can increase inflammation in some patients. So the way I see it is that the ketogenic diet is a really important therapeutic diet. I think it's designed to be used as a pulse, usually for 4 weeks. And in that context, I use it as an N of 1 experiment. So there's some patients who raise their LDL. LDL goes up about 10% on a ketogenic diet in some patients. In some, I would say the minority, they have increased inflammation. So if I have a patient who stays on a ketogenic diet for more than 4 weeks, I like to do a screening test to be able to track inflammation. Maybe in this context, the CardioZoomer might be a good fit, Adair. Maybe combined with the Cardiogenetics test, so that if someone is treated for more than 4 weeks, we've got a sense of what their risks might be associated with that. But I use keto a lot, and I think, we didn't talk about this today. The female brain really changes after 40. And one of the things that happens is that as the mitochondria become more impaired in the neurons of the female brain, there's less metabolic flexibility. And the female brain has about a 20% decrement in its ability to use glucose. And so I think a ketogenic diet can be really ideal to help with cognitive function in women over 40. So that's why I like to use it in an N of 1 experiment for 4 weeks. So yes, I'm a big fan of keto, but I think it has to be adapted for women. So the classical ketogenic diet that's been so well proven in men, and also in folks with seizure disorders and other conditions, women tend to need a little more carbohydrate to do better with their sleep, thyroid function, serotonin production. And so I don't use the cutoff of 20 grams of carbs. I like to play with carb limits using, I I use continuous glucose monitors, and I test for ketones. I look at the glucose ketone index in my patients. So you can still use a ketogenic diet. You just might need to be more liberalized with carbs.
Love that comprehensive answer. Thank you so much. Next question. Can you elaborate more on the concerns with MHT for people with greater than 10% ASCVD?
Yeah, I mean, so I think I've treated probably 20,000 women with hormone therapy. And the number of women that I haven't been able to treat because of their ASCVD risk of greater than 10% is like less than 5 people. So this is the minority of women.
Mm.
And what we know right now, if we take kind of the other stance, is that about 73 to 75% of women who deserve treatment with hormone therapy are not getting counseling about menopausal hormone therapy. So this is when the clinicians on the call really have an opportunity to serve these women in a different way. So for those women who've got a risk that's greater than 10%, the 5 that I've treated over the past 30 years, those are the women that I work with a cardiologist to really make sure that that's the case. And we might have to do some additional phenotyping. So for instance, if they've got an elevated calcium score, I've got a patient, for instance, got a score of about 100, and we found this in her 40s. And so the cardiologist ended up putting her on a statin and treating her. And then once she was stable, we ended up adding menopausal hormone therapy. So I feel like this is one of those case by case situations where I don't want to give a global answer, but I'm also not a cardiologist. And so that's where I'm going to team together with a cardiologist so that we can choose the safest thing. And patients like that, you end up doing, carotid artery intimal medial thickness testing. You might do an echo. You might look at more advanced testing just to really make sure that you're phenotyping that patient well.
All right.
And also, let me add one more thing. Mark
Go ahead.
Houston has reversed calcium scores in his patients. So this is something that's kind of emerging right now, and you should track some of the findings that he's had. But he's, there's not many publications showing reversal of coronary artery calcium scores, and I think that's a really critical thing to be tracking in the future.
All right. Well, stay tuned for that. Exciting. I think we have time for one more question. Where do you find an integrative cardiologist and 24-hour home blood pressure monitoring?
Yeah, such a good question. So, I live in the Bay Area. So Nicole Harkin is the integrative cardiologist that I always think about. Ethan Weiss is also at UCSF. He's been on Peter Attia's podcast, so you can listen to some of his talks. I think the best place to find them is to go through the Institute for Functional Medicine, also the Academy of Integrative Health and Medicine. Those are places where integrative cardiologists tend to hang out. And then for the 24-hour blood pressure monitoring, there's new technology that's heading our way. I just was talking to Kayla Barnes, who's a leader in female longevity, about home monitoring. And you could also reach out to Mark Houston and his team for the device that he uses. I've gone to his office for the 2-day evaluation that he does, where he sends you home the first night with the blood pressure monitor that goes off every 15 minutes while you're trying to sleep. But it really gives you a lot of data. But I think the technology is changing. He's got a device, that squeezes your arm every 15 minutes. The technology is getting better. And even the Oura Ring can help you. Here, I'll put my ring back on. Can also help you with looking at blood pressure and pulse wave.
Wonderful. Thank you so much, Dr. Saul, for the up-to-date, latest and greatest in women's cardiovascular health. Thank you, audience, for being here, for all your questions. Until next time, stay vibrant, everyone.
Thank you.
This webinar is for educational and informational purposes only. It is not a substitute for professional medical advice, diagnosis, or treatment. The views expressed by guests and hosts are their own and do not necessarily reflect the official policy of Vibrant Wellness. As always, consult your healthcare provider before applying any recommendations that you have heard here today.